after lunch. First thing on our agenda is the pledge allegiance to the flag. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation under God, indivisible, with liberty and justice for all.
Jesse James just dialed in.
Oh, okay.
687.
Okay. Dr. Jameson, we see you. Can you hear us?
Yes, sir, I can hear you.
Okay. Thank you. The first thing I need to mention is at our last meeting, we did not have a quorum. So there were no motions, there were no official actions taken. So today we will be covering some of the action items from our previous two meetings today. Any questions on that? Okay. The next item on the agenda is our public comment session. Do we have anyone here who wishes to make public comment? Well, we have a silent bunch. Second call, third call. All right. There appears to be no public comment from any guests today. We will move on with our agenda. Now, like I said, we did not approve the agenda at the minutes from July 27 or September 21. And so the motion today, you can do it one at a time, or you can do it in one motion for the minutes of those two meetings. What is your pleasure?
Mr. Chairman, I'd make a motion we approve the consent agenda as here presented.
Of both meetings?
Yes.
Okay. All right, we have a motion to approve the minutes from July 27 and September 21. Is there a second?
I'll second.
Thank you. We have a second. All in favor then of approving the minutes from these two meetings indicate by saying aye.
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 Thank you. The motion passes. The also in this consent agenda today, you have the division reports. We adopted the minutes. We can have a motion now for the division reports and the contracts, or you can have separate motions. The contracts actually were the same contracts that were presented at the last meeting, and they have just been carried forward to this meeting today to get final approval from this board. So for the division reports and the contracts, what is your pleasure? Do I hear a motion to, normally we approve the consent agenda all in one motion, but since the double up on the minutes, we've approved them. Now we need a motion to receive the division reports and the contracts.
Mr. Chairman, I would move that we approve the contracts and the division reports
Thank you.
as here presented.
Is there a second to that motion?
I'll second.
Thank you. Any other comments? All in favor indicate by saying aye.
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 And thank you, the motion does carry. Okay. Glenn, you were part of our reason for a lack of a quorum, but I think you had a good excuse.
I was airborne at the time, yes.
Yes.
Way to Egypt.
Glad you got your feet on the ground now.
As far as executive council trustee report, I don't recall that we've had any meetings as trustees since our June meeting. We haven't had any more. So nothing to report, Your Honor.
Yes.
Yes, Glenn, there has been some discussion with District 7 now. They, I forget his name off the top of my head, that is the new chair of your group. But they have presented a draft of the document associated with IAB. And as directors, we have received that. I haven't had a chance to go through it, but I will forward that to you so that you can begin reviewing that. I just recently got that. So
Okay.
that's the only action that's happened.
Tuesday. Okay.
All right, so Secretary, just record no report. All right. We've already heard from this young lady once today, but I think she's worthy of being heard a second time. Jenna?
Another presentation for you.
You
Well,
have the floor.
Mr. Chairman and members of the board, today I'm going to provide you just with the clinical services update. And if you flip to the third tab in your booklet, you can follow along with me, or Jessica's got the presentation slides up on the screen as well. So 2023 Board of Health update. So the first slide we're going to cover here is just kind of a look at our patient population by demographics. The column over on the right-hand side is really a percentage average from 2019 to 2021. I kind of take that with a grain of salt. Of course, that was throughout the major COVID years, so it could be skewed slightly just based on changes, going on in the world at that time. The column on the left-hand side is our current patient demographics and what makes up our populations. So starting with children's immunizations, currently that program makes up about 5% of our clinical demographics. That is a substantial decrease from what that used to be in the past. It's been well documented that throughout the COVID pandemic, vaccine uptake has decreased substantially. But we also had the Medicaid expansion that took place during this time period as well, which really allowed patients who didn't previously have health insurance to be covered by Medicaid, which really gave them the freedom to seek care at their pediatrician's office. So a big change for us. So we're kind of watching that as we see the changes with Medicaid as well. Adult immunizations, this is things like travel vaccines, tetanus shots, things like that. Routine vaccines has remained level at about 17% of our current patient demographics. Flu vaccines are down substantially as well, down from 27% to now about 17% of our demographics. Again, every pharmacy, every grocery store, everybody offers the flu vaccine. They seem to be offering that earlier and earlier and earlier every year. So people really have an easy way to get the vaccine anywhere that they would like. So I really believe in my heart that that probably is contributing to that. STD testing, treatment, counseling has remained level in our clinics at approximately 7% of our patient population. Family planning services is currently about 32% of our patient population. I would urge you to take the 20% from 19 to 21 with a grain of salt. Typically, that program does make up about 30% of our patient population, so I really don't think that it has increased that much. Also, again, throughout the COVID years, people really didn't seek healthcare services the way that they would have, in regular life. So that kind of contributes to that as well. Care Plus is always that kind of catch-all category. Care Plus is the category that captures everybody who doesn't fit into one of these other categories. This makes up primary care services. This has been a substantial jump. from about 11% of our patient population to now making up about 20% of our patient population. Things that contribute to that, we have a large influx of patients moving to the area. They have a hard time getting established with primary care providers. So our providers really meet the needs of those patients where they're able to come in, get continuation of blood pressure meds or, whatever they need to carry them through until they get established with a primary care provider. We're also a Healthy Connections provider. That is a program through Medicaid where Medicaid patients can enroll for primary care services, and they may be assigned to us as well as many other providers in the area. So I think that is where we're seeing an increase in primary care as well. And then Women's Health Check is a small but mighty program. It consistently makes up about 2% of our patient demographics. This is a grant-funded program that provides cervical cancer screenings and breast cancer screenings to women in need. Again, about 2% of our patient population. The next slide is one I don't think I've ever talked with you about, and I'm not sure that many people know that this is a service we even provide. In Benewah County, our public health nurse actually functions as the school nurse for 3 school districts there, St. Mary's, Kootenai, and Avery school districts. Of course, it would be very costly to the taxpayers to try to hire a school nurse for all 3 of those schools. So this is an arrangement that's worked out very well for the school districts up there. So she provides vision screenings, hygiene classes. She teaches puberty classes to the 5th grade students. Those are not co-ed classes. She teaches one to the boys and one to the girls, lets them know how their bodies are going to be changing. She teaches a 7th grade growth and development class. She does scoliosis screenings. She works with the schools to analyze immunization records and help bring students who traditionally get vaccines up to date and current on their vaccines. And then she's provided a lot of trainings and education to the faculty and administrators, such as Narcan trainings, Stop the Bleed trainings, first aid and CPR. She did an EpiPen training last year, teaching administrators how to administer an EpiPen to a student who was experiencing anaphylaxis. And she participated in a student health fair. So I just thought I would throw that in there to let you know what amazing work she's doing up there. And then we'll move right into clinical updates. I think services are finally kind of starting to normalize as we've come through COVID a little bit. That's not the focus of everybody's mind when they come to the public health district at this point. Services are really kind of normalizing. The next item I have on here is a partnership that we started with the Kootenai Health Residency Program back in June of last year. This is a fabulous program. We partnered with the Kootenai Health Residents to bring Dr. Chase and a medical resident into our clinics here in Hayden twice a month. Again, it's been an outstanding partnership. That has brought over 150 additional patients into our clinics to seek care services from her. It provides a great opportunity for their residents to experience public health nursing, public health medicine, I guess I should say. And it's a wonderful opportunity for our nurse practitioners to be able to consult with a medical physician as they experience more complex care and get some assistance there as well. On the next slide, if you followed along with the division reports, you've seen both of these mentioned probably every single month for the last year. We are hiring. It seems like we've always been hiring in the clinic, and we have had some positions that have been very, very difficult to fill. Cindy Barnes, one of our amazing nurse practitioners, retired in June, and her position has remained open, and we've been unable to fill that position, which has been very challenging. We did just actually extend an offer to a nurse practitioner yesterday, and she accepted, so we are very excited. She will be covering Hayden and the St. Mary's clinics. We are currently interviewing for an LPN or an MA here in the Hayden Clinic as well. And then in some cases over the last year, we've made the difficult decision not to replace some positions as they have left. You know, we've analyzed our budgets. We're trying to be fiscally responsible. Patients' visits are down in some of our northern counties, such as Bonners Ferry, and it just doesn't make sense to hire a nurse to cover that. So we've had to make some adjustments in that area where we are training one of our clerical staff members to get blood pressures in room patients and assist our nurse practitioner, Mary Fiedler, who goes to Bonners Ferry once a week. So yeah, that's been kind of a change and something we're trying to navigate through some of those changes as well. Another item that's been in your agenda for the last year plus has been the Binks point of care STD testing. I had actually kind of given up hope that this was ever going to happen, but lo and behold, the machines actually did show up here. So we are now able to offer point of care STD testing for chlamydia and gonorrhea in both Hayden and the Sandpoint offices. Right now, our lab results are being sent to CDD, a lab in Texas, which of course has a turnaround and lag time. This will allow us to positive test results in 30 minutes, which allows us, again, to initiate antibiotics and partner therapy much quicker. So that's something we're very excited about. And then flu vaccine clinics. Of course, we're coming through flu vaccine season. All of the data hasn't exactly been tallied exactly yet, but we have partnered with over 35 community partners, people like NIC, Coeur d'Alene School District, many of the long-term care facilities, DHW, county, city buildings, to help vaccinate their staff. And to date, we have partnered with more than 35 locations and administered more than 1,000 flu vaccines throughout the season. Okay, moving into Care Plus visits, we kind of hit on this one already. Again, that's a growing patient population that we're seeing in our clinics. We did purchase a new 12-lead EKG last year using grant funding that we acquired for the partnership for Dr. Chase. So we're trying to up-level some of the equipment that we do have to meet the needs of those patients as well. All right, immunizations. Everybody's favorite topic, COVID. COVID was privatized this year just a few months ago. When we began the pandemic, our role was sort of almost not optional. You know, the federal government administered vaccine to the state administered vaccine to the health districts, and we were in the position of having to distribute COVID vaccine to every provider in the counties that administered the COVID vaccine. We are no longer in the business of distribution, thankfully, that ended, but the privatization did not go without some hiccups. It's been very challenging for us to get COVID vaccine. We do have patients that are asking for that. I think that was probably the number one question I got through our flu clinics was, when can I get my RSV and my COVID vaccine booster? We simply could not get them. We pre-booked a small dose of both Moderna and Pfizer, and I believe we just started to finally receive that last week. So kind of been dead in the water on that. And then it's worth mentioning here that about a year ago, the state came out with the additional sub-grant funding for the COVID work that we were doing, which was really distribution of vaccine. That was a $1.2 million grant that we made the decision not to accept. The work that they wanted us to do, the scope of work, was just really not in line with what the vision was that we had for COVID vaccine, which was really that it would become a vaccine that we offer in our clinics. If patients come here seeking it, they can get their vaccine. But we were really past the after-hours COVID clinics, the big, massive mobilizations and all of those kinds of things. We just didn't really feel that that was where we were going with COVID vaccine. So we made the decision to not accept that grant funding. That was $1.2 million. And to date, we are the only health district in the state of Idaho who did not accept that funding. Moving into RSV. We do carry a small amount of RSV vaccine for, I believe it's those over 60. We've had a lot of people asking for this. However, it is not covered by most insurances. So unless people have the ability to pay for that, it's running about $300 a dose. And while there is a huge interest from the public in that, a lot of people are not pursuing that vaccine. So we do have a small amount of that. Pediatric vaccines, we really recommend, just like COVID, that patients visit with their pediatrician or their physician about whether those vaccines are right for them. And we would really prefer that those patients seek their vaccine from their pediatricians. And then finally, just a couple updates, and we're almost there. Again, the COVID vaccine, that was additional funding that we declined. Family planning is an interesting one. If you refer back to the previous slide, our family planning patients make up about 32% of our patient population. And every year we're told that family planning funding should remain level. And for the 2 years I've been here, that has not been the case. Our family planning funding decreased by about $95,000 over the last 2 years. So that is a substantial amount of money that we are trying to navigate and provide the services to these patients. So worth noting. The Rural Healthcare Access Grant, this was a $35,000 grant that we obtained to support the partnership of bringing Dr. Chase into our clinic this year. Unfortunately, it was very, very competitive this year, and we did not receive that grant award. However, the benefits of that program far outweigh the $35,000 grant, and Dawn and I made the decision to continue that partnership, to continue to bring Dr. Chase and a medical resident into our clinics twice a month. So that partnership continues despite the fact that the funding did not. And then Medicaid changes. I think this is one we've talked about a couple of times. Throughout the COVID pandemic, there was a moratorium on people on Medicaid losing coverage. They just weren't evaluating people for eligibility. A few months ago, that changed. The state of Idaho really started to evaluate everyone for eligibility and end coverage for people who were no longer eligible. And we are being told that that is about 60% of Medicaid patients that are no longer eligible for Medicaid. Of course, we've had the LUMA transition and a lot of other things that have taken place. So tracking that has been a little bit difficult. But that is something we're keeping a very close eye on, because that's a big question mark as far as what happens with our clinics. Are we going to see a gigantic increase in patients who no longer have health insurance? You know, the state says people will just go out to the marketplace and purchase their insurance privately. But, you know, everything that we hear is, you know, in this economy with the cost of living, I am skeptical that people have the funding to just be able to go to the marketplace and buy private health insurance. So worth noting, worth keeping in the back of your minds, but something we're kind of keeping an eye on. And that concludes my presentation for you today. Any questions?
For, yes.
Yes, I was wondering, why is it 60%? I didn't understand why.
You know, that's just as the state of Idaho has began analyzing, as they have started to go through all of the patients enrolled in Medicaid, that is what they have verbalized, that they are estimating or finding that about 60% of the people, 60% of the people currently on Medicaid will be losing their coverage. It's just an estimation from the state.
Okay. Did they give a reason or just?
You know, I don't know. You know, they had they had the Medicaid expansion that expanded coverage to people who would not normally have been eligible for Medicaid. I don't think Medicaid expansion changed, so I don't know if
They were making exceptions at the time, maybe.
yeah, I'm not really clear. I don't have a good answer for you on that, or if people have found people were not employed at the time now are working and don't meet those funding. I don't have an answer for you.
Okay. Let's go back and talk about the flu shots. You mentioned that so many pharmacies and other places giving these flu shots. Explain the difference between fee and free.
Fee and free. So if you have health insurance, the fee is billed to health insurance and they reimburse that. So it may be free to the customer, but on the back end of that, your insurance is paying for that. So people come without insurance. We charge just a $25 administration fee for that to make that very cost effective for patients who are uninsured. We do get state supplied flu vaccine from the state for uninsured adults. So the vaccine costs us nothing. So we just charge a $25 administration fee to give them that flu shot.
And do you charge right at the moment, or do you bill this? Any problem with collections?
You know, occasionally on some of like the big drive-through clinics, there may be a number transposed on their insurance or something like that, for example. But our clerical staff and our billing department do a fabulous job of contacting those patients and getting that corrected so that they can bill that appropriately.
Any other comments or questions? One of the things I failed to do earlier in this meeting was to make sure we all were introduced to guests we have here. So I apologize, and let's back up. I think probably everybody knows Jason, or if you don't, you should. And this is Jason Peppin from our environmental section. And I don't know, are you having a presentation for us today?
No.
And there's a gentleman back here, I'm not sure I know
Can I
the,
introduce him?
Yes, please
Mr.
do.
Chairman? Yes, I'd like to introduce Jake Geringer. Jake has been a great supporter of us. He represents Governor Little's office up here in North Idaho.
well, thank you. Why didn't you thump me sooner?
Dereliction of duty. I'm so sorry.
Yes, very much so. We'll take note of that under your review. But anyhow, welcome, my friend.
Thank you.
I apologize for not recognizing you earlier in our meeting.
All good. I'll be back quiet it's over.
I'm very happy to have you here. Guests are always welcome, especially important ones. All right. Anything else then for Jessica, who did Jennifer, who did a fine job earlier today already? Okay. All right, we'll move on. There you are. You're still here. Okay. This is Kim.
Thank you, Mr. Chairman and members of the board. Today, I'm going to provide an update on our community health assessment. And Jenna did mention it briefly today that we do our community health assessment every 5 years. I'll let you get that up. Sorry.
One moment. There we go.
Electronics always work with the
Sorry. There you go. Okay. So we play an important role in the health of our community, of course, in North Idaho. And so we are committed to our vision of creating healthy people and healthy communities. And our CHA, our community health assessment, which we call the CHA, is performed every 5 years in our district. And it identifies the health priorities in our community and drives the goals and objectives of our community health improvement plan. So we make sure that we do that every 5 years because we want to make sure we're staying up to date on what those health priorities are. So the last CHA was completed in 2018, as Jenna stated earlier today. And the last priorities identified were access to care, mental health and suicide prevention, and substance abuse, including opioid prevention. So our last CHA was completed by employees, by PhD employees, but we decided to explore different options to see what would be the most cost-effective way to do our CHA. So we started the process. We looked at the budget and we did an estimate for utilizing our current employees or hiring an employee. So when we looked at the budget, it would be approximately $200,000 to $250,000 if we hired somebody, because that includes one personnel, mileage to all the counties, all the different resources and different materials that would have to be printed, coming up with all of our interviews and our surveys. So everything that would be included. So then we explored the cost of consulting. And so we reached out to 3 different consulting agencies, and Crescendo Consulting Group, they are actually outside of Maine. They were our strongest contender. So made an inquiry, met with the consultants to discuss what our needs are, what our region looked like, and they provided an extensive proposal, and the cost was not to exceed $38,835. So for us, that was a no-brainer, and that made a lot of sense to do compared to what it would cost to hire someone or to utilize our own employees. So why we chose Crescendo Consulting Group. They had a really extensive proposal. It showed their methodology, their framework. So as you can see the little model there, that's the assessment as action cycle. And so they discussed in there how they assess the gaps, needs, and barriers of our community. We looked at the background and the experience of their team. They laid out the tasks very clearly. They would to establish a leadership team and identify and analyze secondary data, conduct focus groups, stakeholder interviews, community member survey, and then also doing a needs prioritization at the end of that to decide what our needs are based on the data that they analyzed. And then they would draft a final report and then help us transition into the community health improvement plan. Also in their proposals that they would have 2 on-site visits to Idaho, which was very important for them to gauge what's going on in our specific community. They provided a timeline, so we're getting close to the end of our CHA. And then also, of course, the cost, like I stated, and then references. So checked all these references. There's about 6 of them I think I called on, all throughout the United States that had utilized them. All very complimentary, very excited that they did their work for them and would use them again. So it's also important to note too with the cost that Kootenai Health has donated $7,500 as well towards this effort. So that brings our cost down to $31,000, approximately $31,000. Okay, so initial tasks. They wanted to identify a point person, and right now that is me. And then also to identify and create a stakeholder list. So we went through, looked at each county and comprised lists that we already had here in the health district with our programs, and then added ones that we thought would be really important to add. And of course, it includes multiple sectors, such as first responders, healthcare, education, childcare, social services, housing sector experts, senior housing services, transportation, I didn't already say that, and faith-based leaders. So beyond that, we needed to establish our leadership group, which is comprised of internal and external partners. So internally, that is our director, our PIO, and myself. And then the other members that comprise our leadership group is Hospice of North Idaho, Kinnicksu Health, Heritage Health, Marineman Health, Benawa Community Hospital, Northwest Specialty Hospital, Boundary Community Hospital, Northwest Hospital Alliance and Kubi Health, and Shoshone Medical Center. So we made sure to have representation from all 5 counties on our leadership group to make sure that they're helping us push this forward. So their job really, the leadership group's job is really to, 1, represent all 5 counties, helps connect to other key partners for discussions throughout this whole process, and also help to provide spaces for focus groups, those kinds of things. And then we establish regular check-ins with our internal leadership group and Crescendo. So we meet right now every other week to make sure that we're on task and that everything is going smoothly. So just a little bit about the secondary data that they have started to collect. Actually, they've collected most of it. I don't know that they're done analyzing it. But they broke it down into domains. So you've got domain 1, which is our core demographics. That looks at our population change rates and trends, age categories, gender, disability status, language spoken in the home. Also, domain 2 would be our social determinants of health or social and economic factors, which look at economic stability, healthcare access, social and community context, education, and our built environment. Domain 3 is our health status profile. So they're going to look at causes of death, incidence of chronic diseases. Domain 4 hones in on behavioral health, mental health status, substance use disorder trends, and overdose deaths, and suicide rates. Domain 5 is risk and access measures, talking about the number of providers that are accessible in our region, whether it's primary care, mental health. They look at maternal and child health mortality. They look at insurance status, and then also substance use and misuse. So they have sent a draft for our review, but I think they're pretty much done collecting that data, but they have not given us their analyzation of it. So with the qualitative data, they held focus groups, which would gather consumers and stakeholders' opinions, feelings, and expectations on the questions they have in our region. So the types of things they asked about are current availability and identification of unmet needs in our region, access to healthcare, basic needs, and community services. They're looking at the adequacy of our current services. Is there enough, if we have those services, is there enough of the services to serve our population? Or in a region, are they able to access it due to transportation? And then resources and strengths that can be utilized to improve the health of our community. And their goal was to conduct at least 6. So they did come here on site in October, the first week of October. They conducted at least, they did 1 in each of the counties, 2 in Kootenai. And then I believe they did 3 more virtual. And then with stakeholder interviews, those were individual interviews that they reached out to people on our stakeholder list. And they were gathering perceptions of community needs, implementation strategies, barriers to success, possible solutions that they could offer, and also to help identify those important community trends. All right, so here we have our community member survey. I did provide the QR code in case you didn't take it yet and would like to. But what we did is we provided that along with the SurveyMonkey link to send out to our community. And this survey is for anybody that resides in our 5 northern counties. So the community insights help to identify those service gaps and strategies to overcome them. And the goal was to collect at least 500 across all 5 counties from multiple sectors. So with the help of our PIO, we had it put on Facebook and LinkedIn. And then also we sent out emails to our stakeholders, the leadership group, clients and participants of our services. And then I also asked stakeholders to send it out to their clients and participants as well. We wanted to hear from everybody. So any member of the community who reside in the 5 northern counties is welcome to take this. And the survey does close at the end of day of November 19th, which I think is Sunday. Okay. All right, so this is the status as of yesterday. We just met with Crescendo yesterday. So they did let us know that they completed a total of 9 focus groups, like I just stated, and they had a total of 50 participants. So there were 6 in person, and they did, 1 in each county and 1 in each county, and then 2 in Kootenai County. And then they did the 3 virtual focus groups with a total of 26 participants, and they had representation from all 5 counties in those focus groups. And for stakeholder interviews, I know that they wanted to do about 50, so they were a little under on how many they wanted to get from that. But they were very happy with the amount of people that participated in focus groups and the amount of community surveys they received back. So, but we did have representation from every county in those stakeholder interviews. We've got 2 in Benewah, 8 in Bonner, 2 in Boundary, 8 in Kootenai, and 3 in Shoshone County. So our community survey was really a great cross-section. I mean, 838 so far completed. So that definitely surpassed the 500 that they were wanting to get. And like I said, there's a great percentage breakdown here of representation from all 5 counties. 70% Benewah, Bonner 22%, Boundary 12%, Kootenai 38%, and Shoshone 9%. Okay. So next steps. Crescendo is going to analyze all the data from the surveys, the focus groups, secondary data, and then they will analyze that and identify gaps and needs. And then we do have a needs prioritization meeting with our leadership group to meet on December 5th. We will start prioritizing the needs through a prioritization process that they have. Then Crescendo will draft a professional final report and executive summary to build the foundation for our strategic activities. And then the identified strategies will then transition into our community health improvement plan, where we will work with community partners to improve the health of our community based on what those needs are. And that is the end of my presentation. Questions?
Questions? Obviously, the purpose of this was to gather data. So then you're going to try to decide which itch needs the biggest scratch.
Yes, Mr. Chairman. Yes. and hoping that we can really hone it into probably 3 major areas so that we can focus on 3 different things rather than a bunch of different
Okay,
things.
when do you anticipate that you could report to us down at the other end how this has really benefited?
I'm guessing January we'll know more about where our CHIP process is going, so the Community Health Improvement Plan. We should have all of our needs identified, I'm assuming, by the end of this month as we go through that prioritization process.
And then has to be a response to the needs, right?
Correct.
This looks like quite a program. Yes, Mr. Duffy, you want to straighten me out? You got a big
No,
job.
I would never even attempt that, Mr. Chairman, but I will, Kim did a wonderful job going over this community health assessment, and this is what drives our strategic plan. This is what drives what we do at the health district. What are the community needs? In the health district, we just don't follow the money. We follow what community health needs are, and if we need money, we'll go and find it. And that's why this is important for us to do this once every 5 years, to make sure we're meeting community needs.
Okay. Any other questions or comments? Yes, go
Mr.
ahead.
Chairman, just a comment. With the development of artificial intelligence, artificial intelligence could do this assessment continuously, couldn't it?
Don't ask me.
Well,
identify.
Our only IT expert here, Mr.
Okay.
Bailey, is Robert, so I would have to defer to that. I don't have enough information on AI, I'm sorry.
He's about to speak.
I think it's a little too new. People are a little too scared of it at this point to make any kind of a judgment on whether we can use it.
Okay, to be determined.
Yeah.
I understand. But
I could see where this could open up quite a discussion, maybe. And maybe none of us know exactly where we're going right now.
well, there's a lot of unknowns, but AI promises to be beneficial in doing a lot of things. I mean, it will be gathering information from throughout the 5 counties, and it could do it on a constant basis and give you inputs on, hey, this is happening. You may want to focus on this for a little bit, those kinds of things. I think it could be a useful
We
tool.
must be open to that.
Yeah, it would be a useful tool. There's a lot of things that are scary about artificial intelligence as well. But I think it could be useful in healthcare.
Kim, don't you dare plan to retire very soon.
No, I couldn't do that.
But we sure,
Jessica James answered.
yes. Question, Jessica, did you have a question or was it Tim? Jessica,
I did have a question.
okay.
I just wanted to know if they could make a comment on how we anticipate this changing, what our best guess is from 5 years ago. I mean, I think one of the glaring things in light of what's recently happened with Kootenai Behavioral Health will be the psychiatric component, but I'm just wondering if they have sort of a hypothesis on what will have changed from 5 years ago to now. Just curious.
I can jump in there if you want, just because I recently got the data from Heritage Health from their 2023 community health assessment. If you would like, let me share with you what they had here. Of course, this was from a separate presentation, so keep this in mind, talking about youth mental health and suicide. But they identified mental health as the most urgent health concern in their 2023 community health assessment. They identified children and youth as the most vulnerable and at-risk population. And they identified challenges such as wait lists, lack of providers, lack of funding, lack of resources, lack of collaboration, and needed services such as more behavioral health providers, residential day services, and crisis centers. So again, that was really focused on what I used for that particular topic, but definitely I think mental health is, I would be absolutely surprised if it wasn't a top priority again.
Sure. Does that help you out any, or anything else you want to comment?
No, I mean, I think that's pretty consistent with what we see just in the community as practitioners as well. No further questions, sir.
Okay, thank you. Tim, did you have a comment? All right, thank you. Anyone else? I can see that we're just barely touching the surface here.
Yep.
But it sounds good. Keep at it.
Almost there, almost there.
All right, thank you. Thank you,
Thank you,
Kim.
Mr. Chairman.
Okay, we are up to the financial report. And while you're getting ready to do that, I know you're already ready. I have here in my hand, I'm not going to read this to you, but here is a letter from the Idaho State Legislature, the Legislative Service Office, which has to do with audits. And this was sent to me dated October 3, a little over a month ago. And in a nutshell, among other things, it just says that we have a fine person at the helm of our finances here in this health district. And I'm not going to talk long, Christine, but thank you for the work you are doing for us. And with that, you have the floor.
Thank you, Mr. Chairman. And as I've shared before, the success of the audit goes to all of our employees, to ensuring that we're meeting our internal controls, dotting our I's and crossing our T's. Thank you. Moving on to the LUMA update. I don't have a financial report. We're still building reports. As Dawn mentioned earlier, the conversion has been challenging and interesting, but what we need to recognize is we've gone from a system, the state has gone from a system that is well over 30 years old to something that is current and is much more integrated with the various modules, making it much more complicated. We've had some bumps in the road. We've been working through those. Our current focus is getting to the point where we can provide financial statements. As I mentioned in our last meeting, we were lucky enough to hire an individual, a project manager, Cherie, to assist us with this conversion. And Cherie came to us with several, about 3 ERP conversions under her belt. So what that allowed for us, for her, she could think about her experiences and be proactive and start asking questions sooner rather than later based on problems she encountered in other conversions. And that has helped us. And I think that has put us forward compared to some of the other health districts and possibly other agencies. So she was able to provide reports to me this week. They're not finalized reports. They're balanced, but there are some unidentified numbers in those reports that we need to figure out where the source information is coming from. But in short, we do have the budget to actual where it is now populated and has LUMA data feeding into it. We have our billing cost reports, all of our other supplementary reports that are needed. are now populated. We just need to prove them out to ensure that the data is solid, it's reliable, that there's integrity there. So in short, Mr. Chairman, that's the report and update on LUMA. I'm happy to answer questions if there are any.
Yes,
Mr.
Glenn?
Chairman, Christine, my question is, do you have an estimated time this would be fully functional, improved?
As far as financial reports, my goal is to have them available for the next board meeting, if not sooner. Simply because we're operating in the blind right now. We have nothing. And we're moving into our fiscal year 25 budget preparation, starting in January. I'll be preparing those templates, and we feed in the first 6 months of the current year in that information. So we're getting to the point where it's critical to have that information so we can be making decisions.
Agreed.
Well, did they anticipate when this new program was put into place? Did they anticipate it was going to take this long to make it work?
We're only 4.5 months into it. This is a huge conversion. And the reporting aspect is really the heavy lift of a conversion because you're building reports from the ground up. And what's challenging for us is it's not our system. We don't have white papers to where we can go and see what the data elements mean in the system. For example, there's a component called cognotes, which there are data elements, blocks of data coming from LUMA that are fed into this system to where we could go build our own reports, download data. And that's what we do. That feeds into all of our monthly reporting. So Cherie has been building those, but it's been, in some instances, trial and error because she doesn't know exactly what a data element might mean or the data that it contains. Whereas potentially if we had white papers that identified exactly what those meant, it would make it much more efficient.
Transition.
So really, in summary, Mr. Chairman, it's not unusual that report writing would take this long and the conversion process as a whole. It's not a canned package. You're building this up specific to your entity, to your agency. So 4.5 months to be making any decisions or being concerned, it's a bit premature at this point.
Thank you. Don?
If I may, Mr. Chairman, Christine tackled that very well. I think the other thing to remember is that the government agencies that we interface in our financial processes are also adapting to this new software. They're going to LUMA and learning it as well. That has its own set of challenges.
Which has been very challenging, if I may add. Yes.
Yeah. So you got to have correct data from them, but they're uncertain because they're going through the transition as well.
It's getting better, but that's correct.
Okay. Okay.
Okay. I'm not going to say anything more because all I will do is dig my hole deeper. All right, so that concludes what you have for us today.
That does conclude what I have to say, Mr. Chairman.
Well, hang in there.
We're trying.
I know you are.
Thank you.
Okay. All right. Well, Mr. Director, it's your turn. You have the floor.
Thank you, Mr. Chairman. A few quick items for you all today. Christine mentioned earlier, we are coming up, believe it or not, to our FY 2025 budget season. That begins in January. That budget, if approved, is effective July 1. But we are beginning that process, and I just wanted to let the board members know that if they have any input on what that FY 25 budget might look like, just to let you know, in January, we will begin in earnest preparing for that budget. The budget is actually presented, I believe, in the May 23rd board meeting that we will have with our county commissioners at that time. So we have some time, that it is a bit of a process. Want to just also let you know that Kim Young and I and Katie Schmier have been out visiting with superintendents throughout the 5 districts. We've been talking about our opioid settlement funds and if they would have needs for some of those. And we've had some excellent discussions with them. And just keeping you aware, we are concerned of what's happening in our schools, and thus those meetings are occurring. I attended in September the Idaho Association of Counties meeting in Boise. Another great meeting. I had the opportunity to visit with many of our county commissioners who were there. That's a great meeting. It's a great place for us to be, to see what are the challenges facing our counties. It's important for us to know that because we're submitting budgets to them, and I felt like that was productive. I've also been out, as I mentioned before, visiting with our legislators. We have 13 of them. I'm not to all of them by far, but those meetings have also been productive. Really positive comments from them as well. I've been happy to hear. We heard earlier about youth mental health. Yesterday was our first meeting on an exploratory meeting about developing a youth crisis center here in North Idaho. We have an adult crisis center of which I'm on the board, and so that is only for 18 years and older. We are seeing, as Jenna so well described earlier, the challenges with youth and mental health. And we don't know where we're going to go with that, but this group is incredible group of very smart people that have a good handle on what's happening in our community. I will keep you posted as that goes forward. We started here several weeks ago now, just for information purposes. We do have a procedure of our staff being able to work from home. They are allowed to work 1 day a week from home. That must be either a Tuesday, Wednesday, or a Thursday. Again, they are fully accessible when they're at home using virtual technology. I will say, though, there is quite a few employees where that is not possible for them. For example, all of our clinical staff, we have patients every day. So they don't have, and there's really nothing for them to do if they were to work at home because they provide patient care. I don't think there's been too many of any of our environmental staff that have taken advantage of that. But we have others that is important. You know, we lose employees to other organizations that allow a much broader work from home procedure. We lost 2 recently. And we also have, like, our epidemiology staff, all 3 of them live in Spokane. And so providing them that option to have 1 day a week where they can do their very important work from home is very important. So this is not a test run. This is a procedure here to stay. And so far, from what I understand, it's going quite well. Finally, in your packet of information today, you will see your 2024 Board of Health calendar dates. And I just want to remind you to take a look at that and getting that on your schedule. It is just wonderful to see so many of you here today, and hopefully with good scheduling. We have thrown out before, this is the last time I'll mention it, if you have some thoughts of a different day or time, we certainly would entertain that. But your calendar is in front of you for next year, beginning in January. And Mr. Chairman, if I may, I've already shown a little dereliction, I might as well continue. You had the opportunity today to hear from 4 of our 7 executive staff team. You didn't have the privilege of hearing from Kate, our PIO, or Jessica, my management assistant, or Sandy, our HR representative. I can comfortably tell you that I have never been more impressed with a group of people in all of my years in my profession. These are articulate people, they are kind, they are passionate about the work that they do, and they're very proactive about the work that we do. This district is very, very lucky to have them, Mr. Chairman. I feel like I gain more from them than what I provide them. And with that, Mr. Chairman, that's the end of my report.
Okay, well, I've just been trying to figure out some way to pick on Jason today. Anyone from the environmental taking advantage of the work at home, or does it not work out at all?
Our challenge in the environmental, section has been that most of the positions are largely field work positions. So trying to balance field work, how we're going to do that by not creating burden in the office and then also making it equitable. So rather than having a formal set 1 day a week work from home, what we're operating under now is more situational. So, for example, if somebody has their sick children at home or some situation that they can't do some work from home, or even just get work backlogs, something like that. So having it more open-ended seems to be the approach that's working better so far, but we're still in the process of determining how to apply it equitably and not create gaps in services in the office. And it's a challenge, especially in how my office is.
Is your vehicle fleet up to where you'd like it to be?
Yes, that's an excellent question, Mr. Chairman. And yes, we've been able to shuffle things around, and district-wide, we have ample vehicles available and to shuffle things around to where staff have safe, reliable vehicles, especially field staff that have to travel difficult field conditions and bad ones and so forth. So Eric does a very good job of trying to get the fleet.
I'll tell you this, around the country, Jason has done a wonderful thing in keeping our health district in good standing. In my years here, it always hasn't been that way. But I really appreciate Eric and Jason and all the folks from environmental. Big job. And sometimes they deal with people who may not always be happy with the rules and regulations, but these gentlemen and ladies have a way of presenting it in a way that they come to understand why. We're not out there just to pick people apart. We're out there to educate and keep our county healthy. Thank you. Any other business to come before this board at this time today? Thank you for the board attendance, considerably better than our last meeting. Always nice to have a quorum. Okay, folks, we're adjourned.